Good afternoon and good morning, everyone. Welcome and thank you for joining the third webinar in the four-part webinar series titled Employing Status-Neutral Approaches to End the HIV Epidemic. This webinar is hosted by NASTAD in partnership with CDC. This webinar series aims to provide person-first strategies for ending the HIV epidemic, prevention and care activities. Incorporating status-neutral approaches into HIV services are a priority for CDC and HRSA. Status-neutral approaches are a highlighted strategy in the National HIV/AIDS Strategy for 2022 through 2025, as well as the Integrated HIV Prevention and Care Plan Guidance for 2022 through 2026. Along with promoting individual interventions, HIV service providers and programs should actively work to address social determinants of health in their communities. Social determinants of health are structural and societal factors which affect health outcomes. They may include education, employment, housing, community engagement, and healthcare access. Social determinants of health can influence whether a person is vulnerable to HIV acquisition, and they can affect whether a person living with HIV stays in care or receives treatment. Applying a status-neutral lens to social determinants of health requires that programs and services are tailored to address the needs of persons regardless of their HIV status. Research has shown that addressing social determinants of health can help advance health equity by reducing health disparities and improving health outcomes. Addressing structural and societal factors are essential to ending the HIV epidemic. Our presenters today will share examples of status-neutral interventions for addressing social determinants of health. This webinar is being recorded and will be shared. Please feel free to use the chat and Q&A functions at any time during the webinar to ask your questions and share your comments. We hope to have time for questions after the presentations. At the close of the webinar, there will be a brief post-webinar survey. We thank you in advance for sharing your feedback. I would like to now invite Erica Dunbar from CDC to say a few words. Erica?
Thank you. Good day, partners. My name is Erica Dunbar, and on behalf of CDC's Division of HIV Prevention, the Program Development and Implementation Branch, we are so pleased to welcome you all to today's webinar. I am providing opening remarks on behalf of my colleague, Maria Alvarez, who serves as our Capacity Building and Technical Assistance Lead. She had a scheduling conflict and sends her regards today. But again, you're in good hands, and thank you for joining us, and we really appreciate you taking the time out of your schedule to attend this webinar. CDC and NASTAD, we are pleased to continue hosting this four-part technical assistance webinar series. Excited about this one, employing status-neutral approaches to end the HIV epidemic, focusing on today's webinar of addressing social determinants of health through a status-neutral lens. And so again, this series does focus on directly funded health departments and community-based organizations and their partners in working to end the HIV epidemic. I want to thank the NASTAD team for coordinating this session and the Chicago, District of Columbia, and South Carolina Health Department presenters who will share local level perspectives for status neutral programmatic successes, challenges, best practices, and lessons learned. So I'm excited to get to our presenters for today. In closing, though, I do want to provide a quick reminder that the Division of HIV Prevention, DHP, at CDC, we remain committed to our ongoing partnerships. And that includes the provision of technical assistance services and assisting with the implementation of the status-neutral approach to prevent and treat syndemic infections, as well as to address social determinants of health and reduce stigma. If there are any questions for CDC, we do have a mailbox. Please submit them to ps20-2010@cdc.gov. Again, thank you for your interest in today's webinar. Please remain safe. Thank you for allowing me to share some opening remarks on behalf of our branch and our division. And NASTAD, I'm turning it back to you. Thank you.
Thank you, Erica. I would like to now welcome our first presenter for today, Dave Kern, Deputy Commissioner of the Syndemic Infectious Disease Bureau at the Chicago Department of Health. Dave, over to you.
Thank you. Just confirming that you can see my screen.
Yes, we can. Thank you.
Great. So thank you to, well, good afternoon and good morning, everyone. Thank you to CDC and NASTAD for the opportunity to share some information with you today. In Chicago, we implement a status neutral model through what we call our HIV services portfolio. We define the HIV services portfolio as the collection of all HIV services that work together to reduce new HIV infections and to increase quality of life for those living with and vulnerable to HIV. We went through a 25-month planning process to inform the development of the portfolio. In this process, we worked hand in hand with our HIV Planning Council, which was re-envisioned in 2012 to integrate planning for HIV prevention, care, and housing. Participation in the overall planning process was robust, diverse, and inclusive, with hundreds of residents providing insights and recommendations into the development of the portfolio. We finalized the status neutral portfolio in mid-2018 when our Planning Council voted overwhelmingly to approve funding across all of our funding sources, not just Ryan White and CDC HIV prevention as they had historically. So this made it possible to create a status neutral system that had one central aim for our jurisdiction's work, and that is to accelerate progress toward getting to functional zero HIV infections by 2030. We define functional zero as the point at which there are so few new HIV diagnoses that the epidemic can no longer sustain itself. So to accomplish this aim, the portfolio laser focuses on two outcomes, and those are increasing the number of people living with HIV who are virally suppressed, and two, increasing the number of persons vulnerable to HIV who successfully use PrEP. In the portfolio, funding is integrated across funding sources wherever possible. We're able to do this with relative ease because all HIV and STI funding is managed in one bureau. So my leadership team is responsible for planning, implementing, and evaluating services across all fund sources. And as mentioned earlier, this also means that our integrated HIV Planning Council can consider all fund sources in their planning efforts. Wherever possible, services are provided in a status neutral way. This means that the same services are available to people living with and vulnerable to HIV. And these services include HIV screening and testing, linkage to care or PrEP, primary care, medication, retention and re-engagement in care, sexually transmitted infection screening, treatment, and expedited partner therapy, and support services. Unfortunately, because of funding limitations, we're not able to directly pay for all support services for persons vulnerable to HIV, but we do set the clear expectation that these services must be made available to clients. So to extend the use of our limited CDC HIV prevention and city corporate dollars, which pay for services for persons vulnerable to HIV, we treat these funds as payer of last resort, in the same way that we treat Ryan White resources. The portfolio also integrates services for other syndemic infectious diseases, including STIs and hepatitis, wherever possible. While the portfolio was developed and launched before the national Ending the HIV Epidemic initiative, it aligns with all EHE pillars and with the state of Illinois' Getting to Zero plan, the National HIV/AIDS strategy, and federal funder priorities and requirements. The portfolio is organized into 4 domains: how-to, housing, health equity, and healthcare. In the how-to domain, resources are invested in projects that raise awareness, educate communities, and link persons living with and vulnerable to HIV to needed HIV services. In the housing domain, resources are invested in projects that increase safe, stable housing for persons living with and vulnerable to HIV to remove barriers to accessing healthcare, including HIV treatment and PrEP. In the health equity domain, resources are invested in projects that address root causes of health disparity, including systemic racism, and projects that build community interest in and willingness to use healthcare services. And finally, in the healthcare domain, resources are invested in projects that increase awareness of HIV status, access to HIV treatment and PrEP, and access to supportive services that help people stay engaged in care. Across all domains, we fund more than 15 different program areas and 56 individual programs. In today's talk, I'll feature 4 examples. This slide shows the 4 domains in the portfolio with the fund sources that support each domain's program areas. So for example, the healthcare domain is funded through 7 different funding sources: CDC HIV prevention, ending the HIV epidemic, and sexually transmitted infection prevention, HRSA Ryan White Part A, Minority AIDS Initiative, and EHE, and City Corporate. In many cases, multiple funding sources are braided to fund individual program areas and programs, a few of which I'll talk about next. In total, we're investing approximately $43 million in our status-neutral HIV services portfolio. The first example I'll share looks at our HIV Resource Coordination Hub in our How-To domain. The Hub is a comprehensive resource center funded to expand the number of individuals, regardless of HIV status, who successfully link to and use HIV services in the Chicagoland area. The Hub provides information and linkage to services and facilitates provision of emergency financial assistance, which is available to both people living with and vulnerable to HIV. We believe the Hub is the first program in the country to implement a centralized model connecting health, housing, prevention, and supportive services. And unlike other call centers, the Hub stays connected to individuals, sometimes for weeks, to ensure their needs are addressed. We describe the Hub as no wrong door. The Hub launched in early 2020, right before the COVID pandemic. In its first year of services, the Hub responded to over 1,400 calls, served almost 1,000 unique clients, and provided emergency financial assistance to more than 300 individuals, totaling more than $600,000. Emergency financial assistance covered needs like rent, utilities, food, and transportation. We're funding the Hub across 3 different funding sources: CDC HIV prevention, HRSA Ryan White Part A, and HOPWA. Like all program areas in the portfolio with braided funding, we were careful to ensure our investments linked back to federally required services and service categories. For example, for the Hub CDC funding, it meets the expectation of providing HIV-related prevention services for persons living with and vulnerable to HIV. For the Hub's Ryan White Part A funding, it implements referral to healthcare, which is a Ryan White service category. And for the Hub's HOPWA funding, it provides housing information services and housing support services, which are 2 allowable HOPWA components. In total, the Hub is funded at $1.9 million annually. The next example I'll share looks at our community development projects in our health equity domain. Community development projects are meant to address the root causes of health disparities through the lens of social determinants of health. We fund these projects to explore the links between institutional and structural factors, including systemic racism, and the use of antiretrovirals for treatment and PrEP. With this information, project partners are developing and implementing structural level interventions to change existing and to create new institutions and structures so priority communities can successfully access and use antiretrovirals. These are not direct service programs, which tend to provide short-term individual and group level interventions. Instead, these programs are funded to create and implement long-term structural level interventions that benefit whole communities overall. Community development projects launched in early 2019 and are focusing on topics like job readiness skills training, a community index of affirming institutions, financial independence and wealth generation, and raising visibility of marginalized communities. We're funding our community development projects with CDC HIV prevention funding, which is designated to serve both people living with and vulnerable to HIV. Each project receives $275,000, and we provide $100,000 to an external evaluator. Projects focus on Black, gay, bisexual, and other men who have sex with men, Latino, gay, bisexual, and other men who have sex with men, Black and Latina trans women, and cisgender Black heterosexual women. So in total, these 4 projects are funded at $1.2 million annually. The next example is housing for persons vulnerable to HIV in our housing domain, which complements our housing programs for persons living with HIV funded through HOPWA. Our Housing for Vulnerables program which is funded exclusively through City of Chicago corporate funds, provides transitional housing for cisgender, gay, bisexual, and other men who have sex with men who use PrEP, with an emphasis on Black and Latino men, since these groups represent a majority of new HIV diagnoses in Chicago. The program uses a rapid rehousing model, which includes housing identification, rent and move-in expenses, case management, and supportive services, including employment support and job readiness training. Because of limited funding, we opted to fund short-term transitional housing. However, we do require our funded partners to identify strategies for transitioning housed clients to longer-term housing options. Between December 2019 and December 2021, the program has housed 31 individuals, 79% of which were Black gay men and 21% Latino gay men. Of clients discharged from the program, more than 2/3 exited to permanent housing. And of particular note, no participant seroconverted while in the program, which is the overarching goal. This program is funded at $750,000 annually. The final example I'll share are our population-centered health homes in our healthcare domain, which are the cornerstone of the HIV services portfolio. Population-centered health homes provide comprehensive, coordinated services to persons living with and vulnerable to HIV to promote successful use of antiretrovirals for HIV treatment and PrEP. Health homes were designed to provide the right services to the right people in the right way. Health homes provide services in 4 categories and include braided funding across 5 different fund sources. The first category, HIV screening and linkage, is funded through Ryan White Part A service categories, early intervention services, and outreach. The second category, services for persons living with HIV, is funded through Ryan White Part A and Minority AIDS Initiative service categories, early intervention services, outreach, outpatient ambulatory, which does include STI screening, treatment, and expedited partner therapy, mental health, non-medical case management, psychosocial support, substance use disorder treatment, and oral health. The third category, services for persons vulnerable to HIV, is funded through CDC, HIV and STI prevention, and city corporate, and includes outreach and recruitment, PrEP-related medical care, again including STI screening, treatment, and EPT, PrEP prescribing, mental health, psychosocial support, and substance use disorder treatment. And finally, the fourth category is additional support services, like transportation, housing, naloxone distribution, and specialty medical care, which are provided primarily through referral to other CDPH-funded programs. Of note here, each population-centered health home is required to provide all of these services, which make these programs very much status neutral. We're currently funding 12 population-centered health homes for a total of $13 million annually. And you can see the funding breakdown here across fund sources. Of note, between September 2019, when the program launched, and February 2021, almost 80,000 people were screened for HIV, almost 650 new HIV cases were diagnosed, almost 16,000 people living with HIV were served, and more than 6,500 persons vulnerable to HIV were prescribed PrEP. To close, I'll walk through how our new status neutral system compares to our previous funding model. In the status neutral system, services are integrated wherever possible. Previously, services for persons living with HIV were separated from services for persons vulnerable to HIV. In the status neutral system, we're funding comprehensive, targeted bundles of services wherever possible. In the previous model, we primarily funded highly targeted standalone services. In the status neutral system, services are funded through braided funding wherever possible. Previously, services were funded through single fund sources. And in the status neutral system, there is a heavy focus on healthcare and biomedical outcomes and significant engagement of the healthcare system. In the previous model, there was a blended focus on both behavioral and biomedical outcomes and limited engagement of the healthcare system. So now for a few lessons learned. First, our status neutral model is inherently focused on HIV treatment and PrEP, biomedical outcomes. So it has a preference for comprehensive integrated programs. In some cases, this has made it difficult for smaller non-clinical organizations, most of which do not provide medical and behavioral health care, to successfully compete for direct funding. However, we found that partnerships have worked well. For example, we have several large federally qualified health centers who are partnering with smaller hyperlocal community-based organizations to extend the reach of services into communities they had not previously served and to benefit from the relationships that smaller community-based organizations have with communities. Another lesson learned is there's not enough funding to cover all needed services, particularly for persons vulnerable to HIV, like housing and behavioral health. However, a small amount of local funding does go a long way. We would not be able to implement our Housing for Vulnerables program if we didn't receive a small amount of resources from the City of Chicago directly. The next lesson is understanding the limits and flexibility of fund sources really is critical, in particular Ryan White service categories. In order to fund the entire system of status neutral services, we are tapping now Ryan White service categories that we've never funded before, including referral to healthcare, which is a category that allows us to use Ryan White funds to support the HIV Resource Coordination Hub. Certainly, contracting across multiple fund sources is difficult, but it is possible. Building community consensus was and remains critical. It certainly has helped us cover some tough decisions that we've had to make. We were very grateful for the time that our planning council spent with us early on when we were developing the portfolio, including a lot of pushback that led to a more comprehensive and responsive portfolio that we're implementing now. And finally, status neutral programming at the client level works, though it does require new service delivery models and time for partners to acclimate. And in some cases, does require breaking up with some beloved programs. For example, standalone behavioral interventions. But those, again, are integrated wherever appropriate into the bundled services that we do fund. So with that, I will conclude my presentation and stop sharing my screen.
Thank you so much, Dave. That was really just comprehensive and just some great examples of things that can be done or replicated in other jurisdictions. I will now introduce our next presenter from the DC Health, from the Department of Health, Ave Maria Smith, who is the Interim Deputy Chief for the Care and Treatment Division of DC Health. So I will now turn it over to Ave.
Hi, good afternoon to everyone, or good morning, depending on where you are. Again, my name is Ave Maria Smith, and I'm the Interim Deputy Chief of the Care and Treatment Division at DC Health HASTA. I want to just thank everybody for this opportunity to excuse me, share with you guys DC's journey into status neutral programming. Can you do the next slide, please? Thank you. So just an overview of the presentation. I'm going to talk about our EMA and what we look like, give you a little bit of background into our journey of status neutral programming and talk about some of those programs, and then conclude with our lessons learned. I want to set the stage a little bit first. You can go to the next slide. DC Health receives several grants that we use to implement status neutral funded programming, namely Ryan White Part A, Ryan White Part B, the CDC Ending the Epidemic grant, as well as HRSA's Ending the Epidemic grant. But to talk a little bit about our region, the Washington EMA is pretty complex. We have parts of all of the district parts of Virginia, 17 counties in different areas. We have parts of Maryland, which is 5 counties, and we have 2 counties in West Virginia, all under our Part A EMA. We are also a Ryan White Part B recipient for just Washington, DC. So some of our status neutral programs span the EMA. and then others are going to be located into specific areas of our region. So this presentation is going to discuss our status neutral programming kind of in 3 phases. We started our original effort in 2019 with regional collaborators. Independently, we've moved on to a second phase, which is still, I would say, maybe in its infancy. And then we are in the process of concluding the competitive funding solicitation for our 3rd phase. So this presentation has most detail about the initial phase, just because we've had the most experience with it and thought that it would be most useful to people who are considering this approach for themselves. So our EMA consists of very fluid boundaries, with the exception of West Virginia. West Virginia is a little bit more remote. Their epidemic is a little bit different. It's more driven by opioid use and affects mostly white individuals, whereas that of the rest of the EMA is largely a sexually transmitted epidemic and affects a different population, which I'll talk about shortly. So next slide. This is kind of the birth of our status neutral efforts. We have a regional collaboration with the Departments of Health in Maryland and Virginia, and that's because our boundaries are fluid with what's called the DMV, DC, suburban Maryland, and Northern Virginia. And what that means is people live, work, and play all across the region. So I live in Maryland, I work in DC, I may get medical care in DC and Maryland, and maybe I play all over the DMV. So there's really the same people seeking services, and that will be reached across the jurisdictional lines. So we partner ongoing with the Maryland and Virginia Departments of Health. There's funding overlap. We found out we were funding the same organizations, sometimes to do the same services. And so we really collaborated to coordinate our response to the HIV epidemic across the region. And we wanted to be able to maximize the use of our dollars. So for the first status neutral effort, we decided that DC, as the EMA recipient and therefore having jurisdiction or having some sort of governance over DC, Maryland, and Virginia, would take the lead on implementing this effort. We used Ryan White Part A funding for its infrastructure. We used the early intervention service category just as sort of a backbone for the program that we developed. Because it's a combination of services and not a standalone category, it allows all of the activities of the program to be encompassed therein. It is important for me to note that we did seek the approval and buy-in from our funder prior to implementing this effort, because it is a little bit different from traditional Ryan White programming. Next slide, please. So we created a regional task force, and we had representatives from all 3 health departments. It was about 11 people. And what we did initially was an environmental scan to see what the landscape of funding currently looked like, what our unmet needs were. And then we came together to really discuss what the program design would look like and how we would develop and flesh out the activities. And I have to give a shout out to Peter DiMartino, who's kind of the godfather of this effort. It is somewhat of a take on an upstream program that he implemented out in Maryland. So we're appreciative of him. And he was very instrumental in the development of this body of work. We also partnered greatly with our Washington planning body, which is called the COHA, the Commission on Health and HIV. We presented this idea to them. We needed to get their buy-in, and we also needed to get the approval for reprogramming the funds. We did make a heavy investment in this work, and we needed them to okay it and be supportive of our efforts. Next slide. So the core elements of our status neutral, our original status neutral program, is that we wanted to create that feeling of no wrong door. Our previous presenter spoke about that also. People had an experience of getting testing services or outreach services through one program and dealing with specific points of contact. And then later, as they may have seroconverted, they're being shepherded to someone else. And there's a disconnect and disruption of services, and people were feeling somewhat isolated and in having to be referred to unfamiliar settings. So trying to get people to be able to receive services no matter what their status was important to us. Also, we wanted to capitalize on rapid ART and PrEP and PEP use. This is a highly targeted intervention, so these people were likely to be reached who were behaviorally vulnerable to HIV or, in fact, HIV positive. So the medication component was critical. We also wanted to have intentional outreach activities, right? Focused populations, very targeted. This is not a stand on the corner and hand out gift cards and offer people a test. We really wanted to be conscious about who we were reaching. Offer them some whole person wellness services, not just related to their HIV status, taking into consideration the trauma-informed approaches and cultural responsibility, responsiveness and flexibility, because they are individuals and sometimes very disenfranchised or marginalized, in great need of engagement and services. Next slide, please. Overall, we're trying to drive down viral load and increase health and wellness of those who may be behaviorally vulnerable to HIV, and to perhaps reduce some of that risk and to offer some harm reduction strategies as well. For us, it was important to try to reach people who did not typically offer services or partner with us on Ryan White efforts. We reached out a lot to known HIV prevention partners to participate in this work. We focused a lot on community awareness, really trying to brand U equals you into the programs, and encourage marketing and innovation and use of technology to reach people. We were really just trying to pull out all of the stops. Next slide. The philosophy here is that we are just wanting to engage people who are living with HIV or who are at risk, and just offer one program, one approach, focusing on the things that they need, not just dividing services by care or prevention. We had a colleague who would always say, don't just give them an HIV test, give them a job. So we really were just focusing on engaging populations that were really in need of our services and our support. If you can move to the next slide, please. We looked at surveillance data across the region, and these were the populations that floated to the top as being most heavily affected by HIV. So we wanted to use, because of the targeted nature of these programs, we wanted to use this as the backbone. So this is the focus population for that initial status neutral effort for regional EIS. It's also important to note that this is, this or a subset of these populations are primarily the target populations for all of our status neutral work that's underway or being planned. So gay, bisexual, same gender loving men, men who have sex with men of all races and ethnicities, Black or African American men and women, Latino men and women, people who use drugs, youth from the ages of 13 to 24, and transgender women and men. Next slide. So the High Five program model is really the pillars, and it's the backbone of this program. So it's find them, that's the outreach component. Teach them, this is education and counseling and testing for test them. Lincoln is connecting people to services, whether it be HIV care or whether it just be general medical care because they are behaviorally vulnerable but HIV negative at the time of testing, but in need of some other care. And then Keep 'em was the real retention piece that we wanted to focus on. This is a prime opportunity where you could engage the individual for ongoing services that were offered not through this program. Next slide, please. So basically of that first initial effort, we did do a funded, excuse me, a competitive funding solicitation, which yielded 21 programs in several parts of our region, as you can see there. There were 6 new partnerships, 3 of which had never had Ryan White funding before. And some of the programs that were stood up were an LGBTQ ballroom program, which was really innovative, programs that focused on returning citizens, and then other programs that focused on transgender youth from 18 to 29. And these are some of the outcomes that we had. We did show some improvement of viral load suppression across the EMA. We're able to link the bulk of customers to preventative services and support services. So it's just some of the outcomes of that initial foray into status neutral programming. And the next slide, please. Here I'm going to talk a little bit about our second attempt. And this was thanks to the Ending the HIV Epidemic grants that we received from CDC and HRSA. So our other grants that we receive regularly and ongoing, they offer a solid infrastructure for services. We decided to use the EHE grants for more innovative approaches. And of that, there's some status neutral programming involved. We really wanted to expand the reach to people who are otherwise not engaged with services that HACA funds or are naive to the Ryan White network. We wanted an integrated health approach, right? So we used multiple funding streams to create blended funding so that we could, in fact, launch status neutral programming. As you may know, CDC programs tend to support HIV prevention and can be used for people who are not HIV positive as well as HIV positive. And then HRSA funds typically are for the use of services for people with HIV and or who are affected by HIV. So we use blended funding because we wanted to offer comprehensive programming irrespective of serostatus. Next slide, please. So integrated health approach. Basically, we want to address people's barriers to care and help them reduce their chronic conditions. And we did a lot of community engagement work through some funding that we received from the CDC. And much of that informed us that people are stressed. Also, what coincided with the receipt of these grant funds is COVID. And that caused a lot of delays and stops and starts. But what we did know is that people were stressed. People needed some sort of wellness services. People wanted some mental health support, but not necessarily therapy or counseling. And this funds allowed us to kind of explore those needs. It also would allow us to build trust with those who are newly diagnosed. And to kind of bring them into care and engage them in the hopes of getting folks virally suppressed and or reducing new infections from others. Okay, with most of the programs I'm going to talk about, the breakdown is probably 60% CDC and 40% HRSA funded, just for your information. Next slide, please. The Ending the Epidemic programs occur throughout our entire administration. The first and the last bullet are nearest and dearest to my heart because they are programs that fall under my purview. The Wellness Initiative was named for the late, great Ron Simmons, who was a big HIV activist in Washington, D.C., who recently passed away. And basically, Ron was a big promoter of mind, body, spirit connection and its ability to improve health conditions. So as we did our research and as we learned from our community engagement feedback, we developed a program to introduce people to alternative therapies, complementary therapies, such as life and health coaching, movement and body practices, yoga, acupuncture, things of that nature, to try to encourage them to either adhere to ART regimens and or to utilize PrEP as needed and to be able to improve their overall quality of life in an effort to improve their adherence to the biomedical intervention that they were using. Data to action and PrEP in housing are still in implementation phases. That data to action is trying to recapture folks that may have been in care at one point in time, have been lost to care. And then PrEP in housing is, excuse me, focusing some efforts on behaviorally vulnerable populations and the great need of housing, which spans across everyone in this area. Care coordination is the idea behind that is we would embed HOSTA or DC Health employees in with clinical care programs, private medical partners throughout Washington, D.C. That see large numbers of people with HIV, to offer them other supportive services and perhaps introduce them to wellness programs, things that may support their customers in achieving viral suppression or managing their overall wellness, and or offer them other supportive services that they cannot get through their current medical provider. We're also in partnership with that one, having embedded a care coordinator embedded in the local jail facility to offer some connection to care and supportive services, primarily focusing on people that will be released soon into the community who are in need of, regardless of serostatus, in need of IDs, medical appointments, housing referrals, employment information. So it's really a kind of a holistic approach to all the needs of customers that are in private medical care systems and those reentering society from incarceration. Next slide. So that pretty much sums up the EHE programs that we have been funding. Again, some of them are still being developed, still being implemented due to delays suffered as a result of the pandemic. And then others have, like the Wellness Initiative, has been in place for a number of months, perhaps 7 months, excuse me. But we're still making our way through. I'll talk a little bit more about that in lessons learned. The third phase of our status neutral efforts is really a homegrown innovation. And it came as we were trying to revamp our Part B programs. And what were our previous funded programs were ending their number of option years. And we needed to recompete our Part B grant funded programs. So looking at what our needs were, once again, our Part A grant offers a great infrastructure. And so with Part B being focused on Washington, D.C., we really looked at what we needed, which was how to move people along the care continuum, knowing that we wanted to have it be a status neutral intervention. Next slide, please. So really, we're focusing on this care continuum after the screening stage. So forgive me, this slide is quite dated. However, it depicts the information very, very well here. This Part B effort that we recently designed, pardon me, focused on, as focus populations here, we focused on African Americans, African American and Latino men who have sex with men, African American women, and African American heterosexual males. And so there really are four components to this program. The first is the linkage to care, or navigation. The second is rapid initiation of ART and PrEP. And the third is treatment adherence and retention strategies. And then the fourth is customer re-engagement and recapture. So the first area is really case finding with navigation and linkage. And the second being the application of PrEP and ART therapies. We are going to offer some assistance with PrEP. One of the things that we know is that PrEP still presents, or access to PrEP is still presenting as a challenge for some individuals. So in using this program, we have made provision to offer some support for PrEP. We'll talk a little bit more about that next. Treatment adherence and retention really is just trying to ensure that we offer people enough support so that they can stay on their medication. And in the event they do fall off, our last kind of pillar is trying to regain access to the customers that were at risk of being lost to care. So we're using really several sources of funding for this. Sorry, you can go to the next slide now. So several sources of funding cover these efforts. We are using the Ryan White Part B base grant that we receive. However, we are supplementing that with local funding, as well as some funds that we generate from rebates. And we are using Ryan White service categories as the infrastructure. We made available outpatient ambulatory health services, medical case management services, mental health services, non-medical case management services, health education risk reduction services, psychosocial support services, and medical transportation services. We made those available to through our solicitation for people to apply to, really making the outpatient ambulatory, medical case management, and non-medical case management the fundamental and required services for this program that's being developed. And so there is some internal burden here in that our programs do have to be mindful of their funding source when they are performing various activities. As I said, Ryan White funds are used for people who are HIV positive, and then our local funds and rebate dollars have a little more latitude. But it is an internal burden presented to us, as we have to maintain separate tracking, as well as the providers that we have funded to implement this effort. And then we created a PrEP DAP program, which is kind of a take on our AIDS drug assistance program for PrEP drug assistance program. So we will help supply PrEP resources as needed, where needed. Understanding that we do not have unlimited funds, but we do anticipate that with what we know about insurance coverage, prior authorization, that supplement hopefully will be sufficient for the Washington, D.C. area. Next slide, please. So I've covered where we are to date with our three initiatives with status neutral programming. And so we have lots and lots and lots of lessons learned, and we're still learning every day. I think the first one, innovation, requires flexibility. And that's a really nice way of saying that you don't know what you don't know. And so sometimes you find out along the way and you have to pivot and course correct sometimes. And that's okay because it's new. And I think that as long as you're honest about that and as long as you collaborate with your funders and your partners and your constituents, that you'll figure most things out. We learned that status neutral approach is, it requires a paradigm shift, not just for us as healthcare, as public health officials, but also for our provider networks, all of our staff. Everyone has to understand what this means. We are so used to offering programming by funding stream, which dictates to whom we can target for service delivery. We learned that having a kickoff meeting before you launch any status neutral program is essential. People oftentimes will see that they are getting CDC funding or HRSA funding, and they will make certain assumptions about the types of programs that they can implement and the types of requirements that are attached. And so when you're doing status neutral programming, some of that goes out of the window, and then you have to really meet with your partners so that everyone can understand the mission and what the goal is. We found that even our most seasoned partners who've been providers of ours for a decade or more, they needed some significant technical assistance to make that paradigm shift and to figure out who they should target, which is more related to who they actually have access to. And in some cases, there was some identity differences. An organization said that they reached one focus population, and really the people that come through their doors look different. So we needed to work with them to help them figure out who they should be trying to reach and how they can be most successful. With respect to data collection, that's really tricky sometimes because as you blend different funding streams, there are different data that need to be collected, reported differently, with different measures sometimes. And so you have to work with your partners, and hopefully you've got a stellar M&E team, monitoring and evaluation team like we do, and they can really help your program people figure out how to implement data collection processes that are not overly burdensome to your funded providers and your service delivery partners, excuse me, and are actually doable. So with most of our programs, I think we're there. It did require some course correction and some retooling for our initial early intervention services effort. We actually had to create a data decision tree and map out exactly what to do in if-then scenarios to figure out how to collect data and how to help our partners collect and report the data that we need. Next, let's create a learning community. So again, this is new. You don't know what you don't know. And if you're honest with your provider network and ask them to partner with you, there's a lot of information that can be garnered from them and from the customers that they're serving. And then evaluation. It's important, it's critical. It's how you'll determine if you're being successful, if you're making an impact. And you can use it to actually change and to fine tune your programming. We need to do a little bit more of this work with our regional EIS programming. I will say that COVID has been the great limitation here. We were sent home like most of the country in March of 2020. However, we were still working on implementing programs with new grants and all trying to adjust to this new post-COVID context. So that's still underway. We will be excited to learn more and to share that with folks as next steps. So next slide. I think that's it for me here. Thank you so much again for this opportunity. Feel free to reach out with any questions or concerns. If I don't have the information, I will connect you to the place or the person where you can get the information. And have a great day, everyone.
Thank you so much, Ave Maria. I'm noticing in both of the presentations so far about merging funding streams. So I'm curious to see what questions we get about that from our participants today. And I really liked what you said. I think you said one of your colleagues said that, you know, don't just give them a test, give them a job. So I think that kind of sums up very eloquently what we're trying to get, the point that we're trying to get across today. Our final presentation today is from the South Carolina Department of Health. So I'm going to now welcome William Tani, who is the EHE Prevention Program Coordinator. He'll be presenting, and on the line also is his colleague Pamela Davis, who is the HIV and Viral Hepatitis Counseling, Testing, and Linkage Program Manager. And they'll both be available to answer questions after their presentation. I will turn it over now to William.
All right, thank you. Good afternoon, and thank you for giving us this opportunity to share some of our Ending the HIV Epidemic activities in our great state of South Carolina. I'll start by giving us some background information. South Carolina is one of the beneficiaries states of the first phase of Ending the HIV Epidemic funding. And so we receive funds from the CDC and HESA to fund our activities. Those activities are mainly championed by the South Carolina Department of Health and Environmental Control in collaboration with the South Carolina HIV Planning Council, which pulls together ideas from community advocates, people living with HIV, service providers, agencies such as the Department of Alcohol and other drug abuse substances, the others, substance abuse and mental health services administration, and the housing opportunity for people living with HIV/AIDS. And so our Ending the HIV Epidemic Plan aligns with the national plan, which is focused on reducing the numbers of new HIV infections by 90% come the year 2030. Our activities are grouped into 4 strategies, otherwise known as pillars. And this include the diagnose, treat, prevent, and respond pillars. And for the purpose of this webinar, I'm going to dwell so much on our diagnose pillar, which is the most important pillar and the gateway to our services. And so our status neutral approach offers our residents the same engagement with our services, regardless of their HIV status. So individuals with a positive test result are rapidly linked to care commence on antiretroviral therapy with the ultimate goal of getting them virally suppressed and staying virally suppressed. On the other arm, those who are found to have an elevated risk of HIV acquisition are comments on PrEP or PEP, and also substance syringe use programs. And these 2 arms, the 2 divergent arms, culminate in one central point, which is a reduction in the risk of HIV acquisition for those who are coming through the HIV negative arm, and a reduction of HIV transmission for those who are coming from the HIV positive arm. So let's take the first slide, please. And so this is how we have expanded our programs. Before we received or we started receiving EHE funding, we had our programs had been supported by the PS 18-1802 grants. And so we were able to expand testing activities in healthcare facilities. But with the EHE funds that have come in after 2029, we've been able to expand our testing activities to include the HIV home testing, which I'm proud to announce here that that program was launched in August 2021, and it allows our residents to take advantage and get tested at home. There's a high burden of stigma in our jurisdiction here, and so individuals will not avail themselves of the services that prevail in the conventional health centers. So with our home testing program being launched last year, they can stay in the comfort of their homes, order a test kit, and in the company of a spouse or of a trusted friend, they take a test and then get the result back to us, and they are rapidly linked to care depending on the result of the test. If the test comes out negative and they are found to be of high risk of HIV acquisition, then we engage them with other prevention services. We also have our HIV mobile testing that has also helped us to address issues of stigma, that's address issues of transportation. In the next slides, you will see how we are greatly impacted by transportation problems. So with the mobile testing, we take services right to the doorstep of our residents, and this has helped with uptake of our services. Right now, we have in negotiations the Walgreens program, which it's at an advanced stage of implementation. And so hopefully when this goes operational in the next couple of weeks, we can also see additional uptake in this. So we're expanding this gateway so many residents can come in, take advantage, be tested, know their status, and then begin to engage with the services we provide. And lastly, there's the real-time data exchange program, which also we are in negotiation now with other stakeholders, which will send an alert to our public health department and will dispatch our data to care team to engage with individuals who show up at the emergency department and they are found to not be in care, and so we can begin to engage them in care. So in a nutshell, these are the programs that we'll be we're talking about in the slides ahead. Next slide, please. So our residents have the option of being informed in an opt-out fashion about the test that they are going to carry out. For example, in addition to other blood work that has been done, our clients are informed that an HIV test will be conducted. That way they have an opportunity of opting out or accepting to participate. We've also used various devices such as our geospatial mapping and also using our HIV incidence and prevalence data to locate where there is a high burden of disease, and so we engage those areas with our HIV mobile testing modalities. So that has helped a lot in creating educational awareness and presenting resources to those individuals who otherwise would not be able to access that. And also we have taken advantage of individuals who show up, for example, an individual show up to get diabetes screening or drug screening or have their cholesterol checked. We have placed services right there at their disposal so they can take advantage and be tested and linked to care. And this is also the HIV self-testing, which I talked about. I'll expand a little more on that. So this is open to residents of South Carolina of ages 17 and above. And so all what they have to do is they visit the link, click on the link, and then request a test kit, and then that is mailed via FedEx. They receive the test, and then they conduct the test at home, and then send the result to us. And then there's a mobile testing and retail pharmacy testing. I will say a little bit more about the retail pharmacy program. CDC data show that 70% of rural dwellers are about 15 miles away from a retail pharmacy. And that is not the same for urban dwellers. Urban dwellers are just within 2 miles of a retail pharmacy. And so with this, we can be able to reach our rural dwellers, which are already constrained by the fact that they are medically underserved. And so the ability for them to see a provider, see a case manager is really a huge challenge. So placing this retail pharmacy at their disposal to conduct testing is a way of really addressing some of these transportation challenges and even stigma as well. Next slide, please. So these are our testing sites in our jurisdiction. We have up to 51 sites that are supported by our local health department. Some of these have been closed temporarily as a result of a shortage of staff that have come with COVID pandemic. There are 9 locations that are supported by our CBOs, and then there are 41 locations that are supported by 3 federally qualified health centers. Our Greenville Memorial Hospital Emergency Department has 5 satellite locations, and so they also conduct testing in all these locations. And then those who assess substance abuse programs have the opportunity of also taking advantage of these various testing modalities we have there. And then once our retail pharmacy program goes operational, we have up to 10 locations that we have earmarked to begin testing soon, with the hope that in the future we're going to expand and have more people take advantage of this testing modality. Next slide, please. And so here is one of our testing modality. We have expanded a little bit more on our mobile testing modality to showcase other resources that we have and services that we offer in addition to HIV testing. So individuals can receive hepatitis C testing during their interaction at the mobile testing event. They can also be tested for STIs, and there is comprehensive PrEP services also. There is harm reduction that is provided during those sessions. And of course, there's wound care. There's individuals who would have come with cellulitis, infections occurring at injection sites. So our professionals take advantage and also treat these individuals. So we offer vaccines, syringe disposals, and telehealth. Our telehealth program has been very, very important in our state, given the peculiarities of our state. Like I mentioned, we are constrained by transportation problems and also stigma. So individuals can stay at home and receive education about, for example, PrEP use, antiretroviral therapy use. And so that helps them circumvent the challenges that they would have otherwise faced if they were to go see a provider face-to-face. And then our referral and linkage to care services have also been very, very helpful to us. We are seeing about 88% of our residents are linked to care within 30 days of their diagnosis, which is really huge. We hope to continue to build on that. Next slide, please. So these are some preliminary numbers that have come in for 2021 between January to December of that year. We had a total of 46,344 tests being conducted. That number has been reviewed as at this moment of this presentation. That number is up to about 60,000 tests that were conducted for that year. And 342 positives were realized. That number has also been updated to 413. And so that is about 40% more than what we saw in 2020. And for the number of tests conducted, we are up to about 50% more than what we saw in 2020. So gradually what we are seeing is, in essence, is that we are gradually recovering from the effect of COVID and going back to our pre-COVID testing numbers in 2019, which were really impressive. Next slide, please. So how have these programs been able to address social determinants of health in our jurisdiction? Like I said, we are cognizant of the fact that by the mere fact that South Carolina is located in the South, it comes with certain constraints. It comes with certain disparities. And so up to 45% of individuals who live in the South account for more than 45% of new HIV diagnoses in the US come from the South, and we are located in the South. HIV mortalities in the South are 3 times more than they are in other parts of the country. And 24% of our residents are rural dwellers. So that puts a huge burden on them when it comes to accessing resources, which oftentimes are prevalent in urban centers. We also are cognizant of the fact that there are populations in our state that are disproportionately affected by HIV. For example, Blacks or African Americans make up 27% of the population, yet they disproportionately contribute to up to 60 to 70% of new HIV diagnoses in our state yearly. And so we are aware of this, and we are targeting resources to take care of these communities that are disproportionately affected. We are decreasing the burden of HIV in our community by addressing or targeting those with HIV, keeping them on antiretrovirals, and keeping them virally suppressed, with the ultimate hope that when they stay virally suppressed, they will not be able to transmit the virus to their sex partners. And there is a preponderance of evidence-based data that attests to the fact that individuals who stay virally suppressed will not transmit the virus to their sex partners. And we are also addressing stigma and discrimination. Like I said, we have we are really challenged here by stigma and discrimination. And so our testing modalities, for example, our HIV home testing that has just been launched, it gives our residents the luxury to test at home, and then that will be devoid of stigma that they would have otherwise experienced if they had gone to a conventional health center. We are also addressing housing challenges in our jurisdiction. We have housing, transportation, substance use is on the rise, and the mental health problems are also on the rise, and we know our people are disadvantaged. So we're using some of these CDC and HESA funds to address these issues. For housing, we have been able to use HAPWA funds to expand on our housing program. And telehealth programs have also been very useful. We are collaborating with the Medical University of South Carolina to expand our telehealth programs to target individuals, like I mentioned, especially those who are living in medically underserved communities, so they can take advantage and benefit from programs like this, like teleprep. We've also used our telehealth programs for our data to care activities to re-engage individuals who have been found to be HIV positive, but they are not in care. So these are some of the resources that are available and which are possible thanks to the funds that we have received for the phase 1 funding. And then I'm here also proud to announce that South Carolina is one of the 3 states that have benefited from the CDC funds PS 2011, which allows us to take care of those inmates who are being prepared for release. And so oftentimes when they are released, they face challenges. And so they now begin to get out of care, and with the possibility of continue transmission of the virus in the community. So with this program, we have named it Reconnect Us. It has given us the opportunity of working with these individuals, working with their case managers to make sure that they are linked to care immediately they are released from detention, and so they can their care can be continuous and uninterrupted. So next slide, please. So what are the successes we have recorded? We have been able to expand our social messaging through Facebook and through other methods like FaceTime, Skype. We have a program here called Tabo Tuesdays, so we have used that to also address some of the myths that exist here about HIV. What is HIV? What does transmission mean? What does it mean to be linked to care? We use that to educate our residents on PrEP. What is PrEP? Who is eligible for PrEP? And so through all these messaging techniques, we've been able to reach out to members of our communities. So we've also increased we have also noticed an increase in uptake in our services. For example, PrEP. in 2017, PrEP uptake in South Carolina was just about a dismal 6%. But today we are seeing an uptake of approximately of almost 20%. So this is huge, and it's thanks to the great work our people are putting in and the messaging that we are putting in to create awareness of the existence of the service, and so our residents can take advantage and avail themselves of these services. We've also seen there are movement of funds or flexibility of funding to rapidly detect clusters whenever they are being diagnosed, and then we get individuals tested and linked to care. So like I said, that we are already linking people at the rate of 88% within 30 days. So we see that as a huge success, and we continue to build on that success. The knowledge of HIV status has been a problem in our jurisdiction. Up to 14% of individuals are living with HIV. They are not aware of that. But that number used to be really huge. It used to be about 20%. So we have worked so hard, and thanks to the expansion of our testing modalities, we've been able to reach out to many of our residents. And now, as we're expanding more and HIV home testing is now in town, more of our residents can take advantage and get to know their status and take advantage of the services we have. Next slide, please. So all these activities are not without challenges. These are some of the challenges that we encounter. There are missed opportunities. Individuals who show up at the emergency department and they are known, for example, to have an existing STI or a previous STI, and we know that people with a past STI or present STI, they have a risk of 3 to 10 times of having HIV acquisition more than those who don't have an STI. And so an individual who shows up with an STI should cause our providers maybe to escalate their care and order for a test. So we are asking that our providers continue to show a high index of suspicion to reach out to these individuals and offer testing services to them. We also in South Carolina we have a very high burden of STIs, and so we are cognizant of that, and we are using all our modalities and resources to make sure that we reach out, especially among adults and adolescents and young adults. We have a very high burden of STIs there because they are young, they are inexperienced, they do binge drinking, they have multiple sex partners, they don't use condoms all the time. If they use them, they don't use correctly, and some of them are still in the health insurance of their parents until they are up to 26. So that puts a huge challenge on them. So we are reaching out to this community and also offering our services. PrEP uptake, as good as the numbers are, we still have challenges with eligibility. Those who are eligible, very few of them get referred to PrEP and get initiated to PrEP. So we are also working hard, to see how we can improve on that. Then we also have some laws that are very stringent, and right now our syringe service program has not been approved, and so we'll not be able to take care of federal funds that are available to that effect. But we are hoping that in due course that will be addressed, and then our residents can be able to take advantage of that. Bidirectional data sharing remains a challenge in our jurisdiction, and so it delays our services. Lack of Medicare, and like most of the like some of my previous individuals who have spoken before mentioned, it's a challenge here in South Carolina. And so since individuals don't have the opportunity of showing up and getting their medical issues addressed, it keeps them very in a situation that they only show up when those problems have become problematic. For example, when their HIV has progressed to AIDS, and then at that time it becomes very difficult, and it consumes more resources to address them. We are also having challenges with our housing program, so we are working hard to make sure that we continue to improve on eligibility and remove some administrative bottlenecks to allow more individuals come in and take advantage of that. Racism, stigma, discrimination remain a huge problem. We are also working hard, to make sure that that is being addressed. That cannot take one day or 1 month to address. So we are vigilant and working hard with our community-based organizers to make sure that they screen for those problems, and whenever they are found to be available, they address them. COVID has come with a lot of challenges. There's a high turnover of staff, clinic closures, so we also face a lot of constraints as far as that is concerned. But we are gradually, like I said, our testing numbers are gradually going back to our pre-COVID period. So gradually we're going to get there. Next slide, please. And these are some of the lessons that we have learned. We want to share with you. I mentioned here that we have relied strongly on the collaborations that we have built with the South Carolina HIV Planning Council. We have built with other service providers, community advocates. That has helped us to really place our services at the doorsteps of those who need them, to also understand the needs of those individuals. So we have incorporated people who live with HIV to come close, sit in those meetings and tell us, what do you really need? How do you want us to serve you? And so they have a voice at the table, and this has helped us in no small way in service delivery. We've also improved interdepartmental collaboration. Like I mentioned, we have teams that work on HESA funds, teams that are supporting CDC activities. So we have tried to break down all those silos and say, hey, we're a team. Eventually, it is all about ending the HIV epidemic in our great state of South Carolina, and not about the various programs that we are supporting. So that has helped us, with program delivery and effectively. And finally, we I would want to state here that ending the HIV epidemic in our state of South Carolina is not just about meeting grant deliverables. It's about humanity. And we've been able to put our residents at the center of all what we do in a non-judgmental fashion and devoid of stigma and discrimination. So with this, I have come to the end of my presentation, and I thank you all for listening.
Thank you so much, William. I think that all of the presenters today have shared some really different perspectives and unique ways of addressing social determinants of health in their communities. So we have a lot of questions from our attendees. Since we're getting close to the end of time, we'll do our best to get to a few of them. And then what we will do is, for those questions that we're not able to get to during the webinar, we will share the written responses for those along with the recording and slides. So I will share the first question. I think this first question is for Dave. Dave, you mentioned that smaller CBOs may not be able to compete for some of these grants, but that partnerships between larger integrated programs and smaller CBOs have been very successful. Do you have any recommendations for sustaining smaller, potentially non-funded CBOs in this new framework, given that CBOs can critically amplify the capacity and capabilities of larger programs?
Yeah, can you hear me?
Yes.
Yep. Yeah, we made the choice when we released our funding opportunities to not require partnerships between organizations for any of the programs that we fund. In retrospect, having seen the success that many partnerships have yielded through the projects that we are funding, I think we might revisit whether or not we do require those sorts of partnerships, because our programs, for the most part, fund medical care, behavioral health care, and housing. A vast majority of our resources go to those things. We believe that that is one way that we can proactively ensure that smaller organizations that do have deep community connections and access can continue to provide the important services that they do. And we're also looking for other program areas that smaller organizations are uniquely qualified to provide, things like reaching communities to provide on-the-ground point-of-care testing for HIV, potentially other syndemic infectious diseases, and helping individuals from communities navigate to the health homes to receive services. So yeah, we definitely believe that these organizations are critical to our response and are continuing to think of ways to ensure that they continue to fit.
Thank you. And I will open up that question to our other presenters if you have anything you'd like to share in terms of partnering with community-based organizations in your jurisdictions.
Yeah, this is William. I mentioned in my presentation that one of the lessons we have learned is trying to create those relationships as strong as they could be. Most of the funding we received from the CDC and from HESA, we release these grants, to our community-based organizations. They are the ones that really carry out those activities, be it HIV testing in the community or PrEP referral. So we have kept a very strong relationship with them. We've built the partnerships. We meet with them from time to time. We encourage them to join us in our meetings. They are strong participants in HIV planning council, and during observances, they have a conspicuous presence. So we have encouraged them. We have provided them with the tools that they need to succeed, the training that their staff need, and then we've opened up communication channels for them to reach us anytime they have concerns or anytime they are feeling challenges with, for example, meeting their grant deliverables. So that partnership has really helped us to achieve so much of what we have achieved already in our great state of South Carolina.
Thank you. All right, I think we have time for maybe one more question. For the in South Carolina, for the mobile prevention services, two questions. One is how do you promote the mobile prevention services? And then the second question is, how do providers follow up with patients who go through these services?
Yeah, a lot of our services, like I mentioned, we have various activities that we are using. For example, our Taboo Tuesday program, it helps us showcase a lot of what we are doing as a state. We bring it down. We get individuals who are also living with HIV, to participate in these programs and share with our residents how much of what benefit that these services are to them. And so through this, we've been able to showcase and sell, do a good messaging out there. We also have programs like we use FaceTime and Skype and all dating sites like Grindr, to reach out to these individuals and let them know that these services are available. And so our residents have been able to take advantage of that. And once an individual is found to be maybe positive or would need additional services, we have a team of case managers that will follow up with them and then link them up to the level of care they need. Maybe they need referral services or they need to be sent to other areas where they can have additional help. So that has made our program very successful. As you saw in the slide I shared, there is so much that we're doing in a syndemic fashion, to really expand those services, and not just about HIV, but other services to make sure that we address, especially STIs that are the burden of STI is very, very huge here in South Carolina.
Yeah, thank you so much. So we're getting to the end of our time. As I mentioned before, we will be sharing the recording, the slides, and answers to all of your questions in a follow-up within the next 2 weeks. I want to thank all of our presenters today, as well as CDC, and all of you for participating. Here is our contact information. as well as information on how to request CDC capacity building assistance or technical assistance. When this webinar ends, there will be a post-webinar survey. It's 3 questions. We would greatly appreciate your feedback. And thank you for joining us today. Have a great rest of your day. And we hope to see you for webinar 4, which will be in March. We'll be sharing more information about that in the next few weeks. Thank you.
You.